Pathophysiology of type 2 diabetes mellitus. By definition, diabetes mellitus is a chronic disease that is associated with abnormally high level of the sugar glucose in the blood. There are three main forms of diabetes mellitus, which are diabetes mellitus type 1, diabetes mellitus type 2 and gestational diabetes mellitus. On this tutorial we are going to speak about the pathophysiology of type 2 diabetes mellitus. In type 2 diabetes mellitus, one of the risk factor is obesity. Obesity undermines the insulin receptor, where insulin released from the pancreas fails to bind to the insulin receptors. This is due to high fat content in obese patient. This condition makes the body to perceive as if there's no insulin. This makes the body to activate pancreas to produce more insulin. The body produces insulin until a person becomes hyperinsulinemia. If the obese patient exercises, receptors will be expressed and insulin will bind. Then the problem, diabetic condition is solved. This is solved before the condition reaches to its chronic state. When no treatment or follow-up is done on the above condition, then, more insulin production. The beta cells of the islet of Langerhans in the pancreas will keep on producing insulin to an extent that they become exhausted, hence fail to produce insulin again. This will lead to insulin deficiency. This means that type 2 diabetes mellitus has changed into type 1 diabetes mellitus. So the definition that says, type 2 diabetes mellitus is the type of diabetes mellitus that is due to insulin resistance is wrong, because type 2 diabetes mellitus will eventually change into type 1 diabetes mellitus due to exhaustion of the beta cells of the islet of Langerhans of the pancreas. This scenario expresses the possibility of a patient to have type 1 diabetes mellitus, type 2 diabetes mellitus, or both. The main defects in type 2 diabetes mellitus are such as Number 1. Impaired insulin-mediated glucose uptake by peripheral tissues. Glucose fails to enter into the cells of the body tissues, such as muscles and adipocytes. Number 2. Suppression of hepatic uptake of glucose, as well as incomplete suppression of hepatic glucose output or gluconeogenesis, because insulin cannot bind to the receptors to induce the cascade. Number 3. Impaired uptake of fats such as triglycerides by fat tissues. This will cause triglycerides to accumulate in the blood and cause hypertriglyceridemia. This is similar to both type 1 and type 2 diabetes mellitus, where, in type 1, insulin is not there, so insulin will not bind to triglyceride uptake by fatty tissue. Clinical presentation of type 2 diabetes mellitus. The clinical presentation of type 2 diabetes mellitus are due to severe or chronic hyperglycemia, where glucose accumulates in the blood. These are known as the 3 Ps. These are such as polyuria, polydipsia, and polyphagia. But also, unexplained weight loss. I am going to explain the pathophysiology behind each clinical presentation mentioned above. Polyuria. The increase of glucose in the blood will cause hyperglycemia. Hyperglycemia is not a suitable phenomenon in the body, because it disturbs the hemostatic environment of the body. So, the body will respond by increase of blood flow to the kidney in order to filter the blood and regulate the hemostatic environment of the body. Excessive glucose will be filtered out. Under a normal condition for a healthy person, glucose is absorbed back into blood by the renal system. For a diabetic patient, glucose has exceeded the renal threshold, so it is filtered out of the blood by the renal system and a person will produce sweet urine. Glucose is an osmotic agent. So, glucose will induce movement of water by osmosis, from the blood to the kidney to dilute the glucose, so a lot of water will move out of the blood to the kidneys, and later on, a person gives out a large amount of urine, a condition known as polyuria. So patient will complain about frequent micturition. It is important for the doctor to ask the patient about the duration and onset of the frequent micturition. The reason is that frequent micturition keeps on increasing as time goes. Polydipsia. Due to the loss of water through urination, a patient will finally become hyperosmolar because of dehydration. High osmotic state in the blood will cause the stimulation of the hypothalamus, which stimulates the thirst center, hence, a person will complain with excessive thirst. Excessive thirst will make him or her to drink a lot of water, a condition called polydipsia. Polyphagia. The cells of a diabetic patient does not get glucose for glycolysis, because glucose is outside the cells. So the body will stimulate the feeding center to make the person eat food. A patient will feel hungry and eat a lot, a condition known as polyphagia. Unexplained weight loss. The failure of glucose to enter into cells would cause the tissue to starve. This will lead to unexplained weight loss. Other clinical features. These are such as blurred vision, tingling sensation, or the loss of sensation, erectile dysfunction which is due to neuropathy, impaired growth or wasting, increased susceptibility to infections such as candidiasis and UTI. Diagnosis of diabetes mellitus. The diagnosis involves two parts. These are such as clinical diagnosis and laboratory diagnosis. Clinical diagnosis is based on sign and symptoms but also basing on the main features of hyperglycemia, which are polyuria, polydipsia, and polyphagia. Laboratory diagnosis is based on the laboratory investigations such as random blood glucose, fasting blood glucose, oral glucose tolerance test, and glycated hemoglobin test, HbA1c. For random blood glucose, 11 mmol per liter or greater indicates diabetes mellitus, while 15 mmol per liter confirms diabetes mellitus. Fasting blood glucose for a healthy person should not exceed 7.0 mmol per liter. So greater than 7.0 mmol per liter indicates diabetes mellitus. Oral glucose tolerance test. This involves feeding a patient 75 grams of glucose orally and waiting for 2 hours for measurement of blood glucose. Blood glucose exceeding 11.1 mmol per liter indicates diabetes mellitus. Glycated hemoglobin test measures glucose level for the past 2 to 3 months. It is measured in percentage. The normal percent is 6.5%. If the value exceeds 6.5%, it indicates diabetes mellitus. If the value is 7.5%, it confirms diabetes mellitus. Other tests can be done to test for diabetes mellitus, such as insulin test. By testing the C-peptide that is normally derived from proinsulin chain during the conversion of proinsulin to insulin in the beta cells of the islet of Langerhans in the pancreases. The increase in C-peptide indicate increase in insulin production, which indicates type 2 diabetes mellitus, while absence of C-peptide indicates type 1 diabetes mellitus. Plasma test to check for autoantibody. Urinalysis. Looking for acetone bodies, which gives the features of diabetic ketoacidosis for type 2 diabetes mellitus.